Right, hello everybody. What a great day for YSOA. I'm Amanda Vipond. I'm a consultant anaesthetist in York, and I'm a founder member of YSOA. And so I've been here all along really, and I'm really delighted to be able to present two great speakers to you today. So I'm going to start off by presenting Dr. Anne Mair Hammond Jones, who I'm sure many of you know. She's a consultant obstetric anaesthetist in Hull, and I've known her for a long time since she was a wee trainee. And I've known a lot of you since you were wee trainees, to be fair. And I was very impressed by her bio, because clearly her evenings are not like mine with a beer and Netflix, because not only does she have 4 children, she runs, she cycles and swims. She recently cycled to India, in India. It is possible, it's more than 360 kilometres. And then the other thing that I was really amazed at is she plays the violin, and this year she's in the European, this is why I got this, because I knew I'd get the wording wrong. She's in the European and World Doctors Orchestra, and this year she's going to Australia playing in the Sydney Opera House. Very impressive.
Wow.
So without further ado, I'm going to ask her to present her high-risk obstetric clinic.
Right, good morning. I'm afraid I'm not talking about cycling in India or about playing in the Sydney Opera House this morning. Welcome to Hull. Many of you know me already. I'm Anne Mair Hammond Jones. I've been a consultant obstetric anaesthetist in Hull for 9 years. But I started my medical training in Birmingham, and my very first house job was in medicine at the Royal Shrewsbury Hospital in 1999. And that is me with my dad the day that I moved into the hospital accommodation ahead of starting work. A year later, I returned to start my anaesthetics training in Shrewsbury, and at what became at the time one of the first critical care jobs, I did a year of anaesthetics, 8 months of medicine and 4 months of A&E. Anyway, back to Hull. The high-risk clinic was started on an ad hoc basis by the legendary Ian Russell, who you can see here receiving the Dudley Buxton Medal in 2017. Ian would attend the high-risk obstetric clinic in the Head Road Maternity Hospital and see patients with an additional anaesthetic risk. But there were also women who required an anaesthetic consultation with no real obstetric risk. Many of them wanted to discuss epidurals and spinals or had back problems. So Ian would arrange telephone consultations and spend 15 to 20 minutes discussing anaesthetic options. He also saw the needle-phobic patients and referred them to a clinical psychologist with great success. He remembers one patient who even took her own bloods by term. I'm not sure that'd be allowed now. When Ian retired, Peter Aiken took over, and it became a more formal booked face-to-face clinic with admin support, and this was aided by the obstetric guidance that women with a high BMI should be seen by an anaesthetist antenatally to discuss their options and risk. Peter started using an Excel spreadsheet to record the referrals that were made and what happened to the ladies. I'm still using this spreadsheet today, and it has nearly over 5,000 entries, and it's a useful tool for audit and number crunching, and many of the trainees that have been to clinic with me will have seen that spreadsheet. When I joined in 2015, Peter was starting to think about retirement, so I took over the running of the clinic. In part, this was a selfish move so that I could better understand the high-risk patients that the trainees might ring about in the middle of the night when I was on call. But I really love the time that I can spend with patients when they're not in labour or indeed in pain, and making sure that they understand what we can offer and ensuring that we have a plan in place should it be needed. The criteria for referral for anaesthetic opinion hasn't changed much in the years that I've been running it. The addition of women wanting a postnatal debrief is definitely in part to the Ockenden report. Peter changed the referral criteria to exclude women with needle phobia, as they're now offered referral for psychological support by the midwives. And we only see women with a BMI greater than 45, which differs from the RCOG guidance, and that's in part due to the high numbers and the lack of clinic space. The clinic was a face-to-face clinic with up to 7 appointments in an afternoon. I would see the women, write the letters directly onto Lorenzo, which has improved my typing skills no end. After I've finished, I will review the new referrals that have come in and request clinic appointments, which are made by the lovely antenatal admin team. Then in March 2020, the COVID pandemic hit. Initially unsure of how this would affect our work patterns and fears for patient and staff safety, we cancelled the clinic for 5 weeks. It was then reinstated as a telephone clinic, and this has continued right up till today. Telephone clinics have several advantages. These high-risk women often have many clinic appointments, scans and tests to attend for, and most appreciate not having to take more time off work, travel, pay for parking and arrange childcare. There are some disadvantages though. Women can pick up the phone anywhere, and I've certainly had women answer the phone whilst driving, in the stationery cupboard at work, and in the school playground surrounded by children and other parents with very little privacy. But they often don't mind, even though I check. If they're driving, I usually just get them to ring back when they've parked up. But we do still have some face-to-face clinics because there is a number of women who benefit from that. Certainly if they need a translator, there's every benefit to we still have the luxury of having face-to-face translators in the clinic. And they have the first 2 appointments every week set specifically aside for this, if we need to examine their back or their airway or arrange further tests. So in 2023, I had 426 referrals made, and 2/3 of these were offered clinic appointments. 142 were rejected. A lot of needle phobics are still referred. High BMI ladies who I've seen previously who haven't changed in weight much, and the simple back problems. But there were 182 women with a BMI of 40 to 44.9 who I didn't see in clinic, who the RCOG guidelines suggest we do, and another 481 women who didn't have their BMI recorded, so we're not sure where they were in that scale. Reason for referral, so the high BMI patients and the back problems are the commonest reason for referral. Then we have a very good joint haematology obstetric clinic, so a lot of referrals come from them. And then regional and general anaesthetic problems along with other medical problems. I was just looking at the blood product refusal. In the COVID pandemic, I had a referral for blood product refusal, and I rang the lady up and thinking she was a Jehovah's Witness and I was going to have her advance directive all laid out. She told me that she didn't want blood from somebody who had had a COVID vaccine, and therefore she didn't want blood at all. And then her boyfriend came on the phone and said, I haven't had the vaccine, can she have my blood? Absolutely gobsmacked. Anyway, in Hull, this is just a sort of example of the BMI of patients that booked in 2023. So less than half of the pregnant women have a BMI within the normal range, so 36%. 27% are classed as overweight, 23% as obese, and 5% have severe obesity with a BMI of greater than 40. But there was a big 9% didn't have their BMI recorded. Right, so I'm just going to talk about a few interesting cases, just things that lessons learned, things that we could do, not specific teaching points about the cases that we saw. So case 1, a 30-year-old, she came in with her she was referred with her second pregnancy. She'd had a vaginal delivery in 2020 and had an epidural. The first attempt had failed, but she'd had a resite and that had worked well, given her good pain relief. But postpartum, she developed severe back pain, pelvic pain, and she couldn't feel herself passing urine. So we arranged an urgent MRI scan, obviously thinking the worst, that this was an epidural haematoma. don't know how well you can see these, my lovely neuroradiologist put some arrows on. So basically she had an MRI that was initially reported as an epidural hematoma from L1 to L2, and it was compressing the cauda equina, so giving her symptoms. But it was reviewed by the neuroradiologist, who felt that the location of the hematoma was a little bit atypical, and he was worried that it wasn't just a hematoma. So he arranged an extra scan, and this showed that she had appearances in keeping with an intradural enhancing mass at the L2 level with associated hematoma. So our poor anaesthetist had perhaps inadvertently found a tumour in the lady's spinal cord that she didn't know about. Caused a bit of hematoma, and then that had given her the symptoms. So she was seen by the neurosurgeons, and she did indeed have an intradural grade 1 epidymoma, and that was excised urgently, and she had a good recovery. Post-surgery scans showed she had stable appearances, there was no evidence of recurrent tumour. And then when she came to see us in clinic with her second pregnancy, we were able to get their opinion, and they said that she could have an epidural or a spinal if she wanted in future labours. And that's her post-surgery scan showing no residual tumour. So she's expecting her baby in July, and she's happy that she's got a choice of an epidural or a spinal. You might wonder why she'd want one again, but I guess we found her tumour that she didn't know she had, and maybe that was fortuitous. And the epidural that she had, the second one, gave her good pain relief, so she had a good experience of the epidural actually in labour. The surgeons mentioned that, as we sometimes talk about, epidural scarring may prevent sacral spread of local anaesthetic, so it might not work as well for us last time, and if she needed suturing, perhaps a pudendal block or a spinal could be considered, but that she could have one if she wanted. So this case just shows the importance of imaging and getting specialist advice to aid decision making in future pregnancies.
I was just going to ask, what would have been the prognosis had there been left and not been found?
That's a really good question, and I'm afraid I don't know the answer, but I'll find out. Okay, so case 2 is a case that's actually been presented by Steffi, one of our trainees, as a poster, so please visit her poster and have a look at it later on. So this is a 24-year-old lady who has TAR syndrome, so she has thrombocytopenia with absent radius. She was seen in her first pregnancy in 2019, face-to-face, so it was pre-COVID. And what we noted was that she had virtually no upper limbs, so little hands coming off her shoulders. She could use an electronic wheelchair, but did walk, and she used her lower limbs for most activities of daily living. And that's just a stock picture off the internet of someone with TAR syndrome, and obviously one of the biggest things to consider is that would be difficult IV access, and then we'd need to check her platelet level in labour and see whether she could or couldn't have regional anaesthetic. So in 2019, she was admitted in labour, and indeed she was difficult IV access. Unfortunately, despite a clear plan in her notes, the obstetric team had a lot of goes at trying to get cannula in her legs, first of all before calling the anaesthetist. So then we came, we used an ultrasound scan, but we struggled to get IV access. So she had right internal jugular central line inserted while she was labouring, and that was the bit of the whole labour that she found the most distressing, was trying to keep still, lying flat whilst putting a central line in and having contractions, and that was her main concern for her second delivery. Her platelets were 77, so after discussion with the consultant anaesthetist, it was felt that we wouldn't offer an epidural, but we could offer a fentanyl PCA. But if she needed theatre, then we could do a single shot spinal. But luckily with the fentanyl PCA, she went on to have a vaginal delivery. And again, she became pregnant in 2023. This time I did a phone clinic because I'd met her before and knew what the issues would be. So we discussed a plan for early IV access, measuring platelets, and then again whether or not she could or couldn't have regional anaesthesia. This time, I think it was the lovely Dr. Rayner who looked after her. She was planned for an induction of labour, so we were able to insert the central line before she had her waters broken, and it was a much more pleasant experience for her. But then she did have a difficult ARM and unfortunately had a called prolapse and fetal distress. So a grade 1 section was called, and I think it was Anne who did a spinal anaesthetic for her. Platelets were 87 that pregnancy at that time. She had a 1.1 litre blood loss. So this case shows the importance of planning and communication with the obstetricians to allow IV access to be secured in a timely manner. What would happen if these patients came in the middle of the night needing urgent delivery? It would be difficult. We would have to probably put a central line in with her in pain, and that would delay things. Discussions that we've had in the past, and maybe we could talk about it, the questions, is whether or not having a patient who we know is very difficult IV access, whether we plan early IV access electively at 30 weeks or something so that she could have that just in case. But again, that comes with its own risks and something that would need to be discussed with the patient and the team. So case 3, a 41-year-old who came in with her 3rd pregnancy, but she had a 20-year gap from her first 2 pregnancies, and in the meantime she'd been diagnosed with a Chiari malformation and a thoracic syrinx. It was decompressed. She then developed hydrocephalus and needed a VP shunt, and had functional neurological disorder with a weakness and also anticonvulsants for epilepsy. So this is an example for me of how forward planning doesn't always go to plan. So I saw her in August last year and emailed the neurosurgeons for advice, but that got lost in the email ether. And then she was admitted at 23 weeks in threatened preterm labour, and we didn't have a clear plan in the notes, so the consultant at the time spoke to neurosurgeons. They said that she could have regional anaesthesia if she wanted, and so we were happy now that we had a plan in the notes. Luckily for her, she continued with the pregnancy until January this year, and she was booked for an elective caesarean section because the baby was small for gestational age. But on the morning of the C-section in Hull, we didn't have any NICU beds, so I believe she was sent to York and had her C-section in York. And Dr. Rayner again spoke to the anaesthetist over there and explained what the neurosurgeons had said and what the plan was. So if anybody knows what happened to this lady in York, I'd love to know. And that's her on the left. It shows the Chiari malformation and the syrinx, and on the right it shows the decompression and a reduction in the syrinx. And that's all I'm going to tell you about that. Okay, so case 4 is a 32-year-old. This is an example of multidisciplinary care and planning complex high-risk pregnancies. It's her first pregnancy. She's known to have liver cirrhosis, portal hypertension secondary to autoimmune hepatitis. She also has a hypercellular bone marrow and pancytopenia, and her platelets pretty routinely stand around 30 to 40. She's on prednisolone and tacrolimus, so she's immunosuppressed. So she's being looked after at the moment. She's still currently pregnant with many teams involved in her care. At the moment, most of the teams think that she would be suitable for a vaginal delivery, and I think they would rather avoid a C-section if need be. Haematology are keeping a close eye on her platelets and may increase her prednisolone. And obstetrics think she's high risk for GDM and PET. We'll keep an eye on her, but could have a vaginal delivery if she wanted. For us, one of the disadvantages of the high-risk ladies is the number of clinics they have to attend. And so I spoke to this lady on the phone, and we made a clear plan about what level of platelets and whether she could have a spinal or an epidural. But when she saw the obstetrician, she didn't recall speaking to me at all, which I was gutted about. So luckily, because she had a face-to-face clinic with the obstetricians, one of our registrars went down and spoke to her and gave her leaflets and showed her the website labourpains.org and reinforced all the instructions that we'd given her before. But I guess I have to bear in mind that perhaps our phone calls sometimes just do disappear in the ether, especially if they're taken in the school playground. And this is an interesting case of showing the advantage of face-to-face clinics with in-person interpreters. So this lady had previously had a caesarean section in Hull under a spinal anaesthetic, but I noted that she spoke only Russian, she'd needed an interpreter, and I felt that it would be nice to see her, examine her back, and have the interpreter to go through the risks and benefits of probably having an elective spinal this time in Hull. And when I saw her in clinic, that was all absolutely fine, but she then disclosed that she'd been diagnosed with Wolff-Parkinson-White as a baby in Latvia and had had no cardiology follow-up but still had occasional palpitations. So because she was in the hospital, we were able to send her for an outpatient ECG. And I'm not great at ECGs, but I think I can tell that this is Wolff-Parkinson-White. So it shows a short PR interval, a widened QRS and delta waves. So I was able to email that ECG to the cardiologists, and they gave us some advice. They said that we should avoid the usual antiarrhythmics such as beta blockers and verapamil. We could use propafenone, which is hard to get hold of, or flecainide, and if need be in SVT she could have synchronised DC cardioversion. He did suggest that we consider delivery in Leeds, and I'm waiting for the advice of the obstetricians at the time. However, she did previously have an elective caesarean section in Hull uneventfully, and now we've got this additional information. It may be that that's what we decide to do for her. And the last case is a case of a postnatal debrief. This is a 27-year-old who'd actually been seen in the antenatal anaesthetic clinic during her pregnancy because she was under the care of the immunologists with chronic spontaneous urticaria and angioedema and vocal cord dysfunction requiring 6 monthly Botox injections. The vocal cord dysfunction was worse during mental and physical stress, and it could result in laryngospasm, which she managed with breathing exercises and saline nebs, or in the worst case scenario she would pass out and then the laryngospasm would break, which was not ideal. So we made a plan for early epidural to reduce her pain and stress. She had an epidural which worked well for labour, but when it was topped up for a grade 2 section, it was noted to be unilateral when the surgeon tested with pinching the skin. And we decided that actually, after discussion with the consultant and that we had enough time in theatre, that we would try to do a spinal to give her an adequate block. It was attempted in the lateral position and was difficult, so then she was sat up. We managed to get the spinal in. The trainee managed to get the spinal in and lay her flat. Almost immediately she complained of difficulty breathing, SATs dropped to 98 and she had a block that was noted to C4. So she was reassured, oxygen was given, the partner was asked to leave theatre and she had an uneventful general anaesthetic. The live baby girl was born with no problems and she was extubated uneventfully at the end of surgery. I try and see these ladies about 6 months after they've delivered, but she didn't answer her phone at the time, and I spoke to her just the other day. She had quite a few questions to ask. She wanted to know specific times and events and go through everything. But one of the ones was the fact that the spinal had been difficult to insert and would that cause the high spinal. And I was able to reassure her that really it was perhaps difficult because she was lateral, and then we sat her up, we got it in the right position, and that hopefully wasn't the cause of her high spinal. And that if we hadn't tried a spinal, she would have almost certainly, definitely ended up with a general anaesthetic because the block was inadequate for a caesarean section. Because she was quite atopic, she also had the question that was this an allergic reaction to the local anaesthetic? And I was able to reassure her that absolutely that wasn't the case. In fact, it was very clearly documented on the anaesthetic chart that signs had been looked for an anaphylaxis. There was no rash, there was no bronchospasm, airway swelling, and that we really didn't feel that that was the case, that it was the case of a high spinal. And she was just about starting to think about having another baby. She'd had quite a lot of counselling afterwards. I'd find the whole thing, unsurprisingly, quite traumatic. And she wanted to know if this would happen again. So we talked about her options if she had a VBAC for having an epidural, but making sure that it worked well and timing delivery, about a spinal for an elective caesarean section. She did mention, though, that she was quite scared about going back to theatre and the same thing happening again. So if she went to theatre, she might ask for a general anaesthetic and just go to sleep and not worry about having a high spinal. And if that happens, that's fine. We can't force a patient to stay awake. So what you need to do then is make sure they understand the risks of a general anaesthetic. So what we did was we went through why we'd rather she stayed awake, but why we understand if she wanted to go to sleep, that she could. And she was happy with that explanation. I also then gave her the option, if she should become pregnant again, to be re-referred so that we could talk through all of these things again in another pregnancy. So that's the end of the cases, and I just was thinking, why do we have the obstetric clinic? And for me, probably the top one is the most important: patient information and knowledge, and that aids informed consent and helps their decision making in labour. Many times I think we meet women in pain in labour and you do worry about what their consent, what they're taking on board, and if we'd be able to let them think about it beforehand, I think that's really important. But this is a high-risk clinic, so we see complex patients, and that means that we can see them, investigate them, and get advice from other specialities in a timely manner, and give them the best care. Postnatal debriefs were already happening, I think, as part of planning for other pregnancies, but actually having specific postnatal appointments has helped many women that we see later on after they've delivered. It provides learning opportunities for the trainees who come to the clinic, but also for me. I've learned so much while I've been doing this clinic, which is good. Right, so this is my good friend Laurie Bramfield. We worked together back when I was a novice in Shrewsbury. She's now a consultant obstetric anaesthetist there, and she was the clinical lead during the Ockenden review. So I asked her what she felt had changed in anaesthetics since the report was published. She said that they now have a specific postnatal debrief clinic once every 2 months, and the patients have 45 minutes to an hour face-to-face to be seen in clinic. She felt that the department had much better use of the Royal College audit recipes and much better participation in the MDTs of the department. The reports helped them to recruit obstetric anaesthetists and change the rota for the better. Thank you.
She's running away, but anybody, anyone got any questions for Anne Mair? Oh, yes, okay.
More like seeing all those patients, because it definitely reduce the amount of phone calls we get middle of the night, and I can't imagine making those decisions 2 o'clock in the morning. And one more question: why do you think we don't get these patients in general population? I can't remember anesthetizing anybody with careless malformation or Touch syndrome. Where are these patients?
Good question. I have no idea.
Is there a roving Michael? It's all right,
It's just about the lady who recall seeing you. In my high-risk clinic, I used to send the patients a letter, and I'm just sticking their folder that they had with their notes. Is that something that you'd either do or consider?
So that's quite interesting, because I hadn't. In the past, the letters were just on the patient record, the computer record for everybody else to see, but not the patient. But we've actually just switched over to Badgernet, and the patients have badger notes, so they see now what I write in the specialist review, and I think that was something that should have come earlier, to be honest, and hopefully will help remembering what was spoken to me.
Because the other thing we used to do is that we had a folder on delivery slips, that if these people bowled up and couldn't find out, this was before Badgernet, then it worked really well, but Badgernet is fantastic for information.
So before Badgernet, when I saw them, I would print, and this I took over from me and Russell, I would print their letter and put it in their hospital notes on a bright yellow piece of paper. Well, you'd think you'd be able to see that, but actually it still got lost. And we've got some of the midwives here, you rarely could see it, could you? But I'd also put a sticker on the front of the notes saying anaesthetic alert, so people knew to look for it, or knew to look on Lorenzo. And the trainees maybe wouldn't see the notes straight away when the women come in, but if they thought they were a high-risk patient, then if you looked on Lorenzo, you could find the letter. Badgernet, I was thinking I need to think about whether or not we can have a flag or something. I don't know, do you have a flag for anaesthetic alerts on those that use Badgernet?
Well, we do, because you have got on the system we have, you have to say that you release the information to the woman, so you've got to remember to actually do that.
Yeah. Okay.
I just wondered why you see the patients who refuse blood products. We gave up about 10 years ago, because after all, the only thing an anaesthetist actually specifically has to discuss is an epidural blood patch.
Yeah.
All the other things, the bleeding is caused by the surgeons and the delivery, not by us. And so we decided it was the obstetrician's job to go through the trust documentation for exactly what they would accept or refuse, and make them understand that yes, childbirth can be very bloody and there is a risk of them dying if they won't have blood. so we don't see them anymore.
And I think that's a good point. And we do see them, and I think that's so that we can have a clear plan of the blood products they would or wouldn't accept and whether they would take cell salvage, but that could be done by somebody else and clearly put in the notes, so it's possibly that's a population of women we don't need to see.
Sarah?
So you mentioned that you, capacity-wise, you're unable to see women with a BMI less than 45. Mid-Yorkshire, unfortunately, our cut-off is 50 for the same reason due to capacity. Have you put in place an alternative way of ensuring that women do get information from an anaesthetist, but not through a face-to-face or phone call?
Really good point, Sarah, and I'm looking at Angie because I know her and one of the trainees of in development. We have a leaflet that will be given to the women, and we've got a new healthy lifestyles midwife who's very, very proactive, and so that's something that's not being done at the moment but is in process. And I was chatting to Matt earlier. Do you want to tell them what you do for your...
Yeah, we've made a video. So we've got one of my colleagues, Joanna Ferrier, Tony made it's a really good video actually, which gets sent out to everybody that's got a high BMI above 30. They get a leaflet as well, that's part of anybody, and then it's only if they're above 50 do we see them, and between 40, 45, 50 they get an option to face-to-face to see us. But everybody just gets sent this video, which I'm more than happy to share with the readers, because it's really good.
May I ask how you distribute the video, please?
So there's QR codes, there's a leaflet which they get, and the link to the videos on there. Some of the midwives will text it to the patients or email it to them, so you have it all different modes of distribution.
Fantastic. Just for those that do use Badgernet, if you can put electronic leaflets on Badgernet, and then you can prescribe it to the patients through Badgernet, so you can set it for whichever week you want that leaflet to arrive to the patient with an alert that will come through on their Badgernet saying information leaflet requested to read at week 32 or week 36. So that's another great facility with Badgernet for those that use it. Not that I'm promoting Badgernet. I don't have any shares in it really.
So much about it, I don't know.
So I was just going to say on that, so I'm Nick Roberts, consultant in Nottingham. We recently audited leaflets on Badgernet going to women, and none of them look at them. Sorry.
However, you can tick the box to say that it has been offered to them, which is the goal.
So I think that's the time for questions unless anyone's desperate for one. Right, there's one desperate short question at the back.
Who was the person that had made a video? Where are you from?
Leeds.
Leeds. Can we find it on the internet? I want to see it.
Yeah.
Cool, thank you.
That'll do nicely. So from Leeds, the video. Right, thank you very much.